broken up over 3 weeks. It's a lot of content, but should be a little bit easier than the first one. The first one's a doozy, for sure. It goes a little bit easier after that, hopefully. Okay, so some of this is going to be review. Some of it's going to be new content for you. You might have heard it before while we were in clinicals. Anyway. Questions on anything before we get started? Good. All right, mechanical ventilation. We're gonna talk about mechanical ventilation, oxygenation, advanced airway type stuff, how we ventilate in general, basically just breathing. That's what we're gonna talk about. And then on the second half, we're gonna talk about our ABGs. So we've had ABGs reviewed in the past, and it's really basic interpretation of those ABGs, and now we're gonna take it just a step further. And look at some other values and determine a couple of things, okay? So when we think about ventilation, what do we think about? Buddy?
Breathing.
Breathing in general, okay. What else? Has anybody ever figured out how we actually breathe? Has everybody thought about the process? I mean, I know it's kind of involuntary. We just breathe and you don't have to think about it, right? But have you ever actually thought about the process? So with ventilation, as that diaphragm contracts, tightens up, it causes a decrease in intrathoracic pressure compared to the atmospheric pressure. So with that decrease or negative change in pressure, that's how that air is forced into our lungs, because that air is filling up that pressure space. And that's how we breathe normally. As that diaphragm relaxes back out, the intrathoracic pressure increases, and then to balance itself back out with the atmospheric pressure, we exhale. So that's how we inhale and then we exhale. So that's very important when we're talking about mechanical ventilation or other types of airways, because it's the reverse concept. It's different than we just breathe normally. It's a positive pressure system. We're forcing air into their lungs and allowing them to breathe. So it's a very unnatural, very uncomfortable process. So when we talk about these ventilator changes, these vent settings, you gotta think about how uncomfortable this is to the patient, okay? So that's basically what this slide is gonna talk about, if you wanna read each side. As far as mechanical ventilation, our main goal is going to be to open up those lungs as much as possible, open up those alveoli as much as possible, keep them open for a sustained period of time, allowing for that CO2 and oxygenation gas exchange to occur. The more alveoli that we have open at one time, the better off we are, because we can create more of that gas exchange. If they're not open and they're stuck and kind of sticky together, they're atelectasis that have damage to those alveoli, we can't use those alveoli to have that gas exchange to occur. So we have to recruit more. And that's when we're going to talk about different vent changes, vent settings, to recruit more of those alveoli and hopefully create some better gas exchange from there. So there's several things that could factor into this and why we might need mechanical ventilation. So COPD, maybe they had a big anaphylactic reaction and everything is kind of clamped down, so we're just protecting their airway. Maybe they've had a seizure, something like asthma or COVID-19. Maybe they've had ARDS, acute respiratory distress syndrome, that we're going to talk about next week. A lot of factors can play into this. So think about stiff, non-compliant lungs that are kind of locked down. Maybe pneumonia. You know, we have all that fluid buildup and that sputum buildup inside those lungs that is attaching to those alveoli, not allowing for them to fully expand, and again, not create that gas exchange. So when we talk about mechanical ventilation, we're going to break it down with a couple of different airways. We have things called our oropharyngeal airway, nasopharyngeal airway. We have endotracheal tubes, and y'all talked about tracheostomy tubes as well. So there's plenty of options, plenty of variety as to what type of airway we can use. And depending on our emergent need, we can select any one of these to place and allow us to ventilate our patient or mechanically ventilate our patient. So we'll break it down a little bit further. So we have what's called an OPA, or an oropharyngeal airway. And let's see, where'd it go? I don't have one. Okay, fair enough. Our goal with the oropharyngeal airway is to get it right past the tongue, get that tongue out of the way, and it lies just right above that epiglottis. Our main thing is our tongue is getting in the way of our airway. So if we get that out of the way, we're able to press it down, we're able to ventilate a little bit better, deliver that breath of air a little bit better, because that tongue is up and out of the way from there. With each of these artificial airways, sizing is very important. So when we're talking about sizing for an oropharyngeal airway, we measure from the corner of the mouth to the jaw lines, right there at the angle of the jaw. Because you got to think about where it's being placed. So about corner of the mouth right there to the jawline. And again, we're trying to get that tongue out of the way, pressing it down, and sitting right above this epiglottis. So as we deliver that breath of air, we're trying to get it into that trachea. Okay? With these, very uncomfortable. It's going to trigger that gag reflex. You got to remember where we're at when we're placing these. It's going to hit right there in the back where that udal is, initiating that gag reflex. So you definitely want to use these on unconscious patients only. It has very minimal responsiveness to it. We're not just shoving these down on awake alert patients like ourselves, unless you're just way out there and crazy. Some people do it, but we're not doing it for the awake patients, only the unconscious patients, all right? This is gonna be a very temporary type access until we go a little bit further and we get them to a more sustained facility, maybe like a hospital or a trauma center where they can exchange it for a better airway. They use these a lot out in the field, so paramedics might use these just for a real quick access. I'm sure, Josh, you've used these at some point. Just throwing them in pretty quickly, so. Okay. Next up, something a little bit different, a nasopharyngeal airway. Sometimes they call it a nasal trumpet or an NPA. Very similar concept to the OPA, we're just placing it a little bit different. So we're into the nasal passage right there, and up and back. And again, sitting right around that epiglottis so we can deliver that breath of air and hopefully get it into the trachea, down into those lungs. This one doesn't hold the tongue back quite as much as the oropharyngeal airway. But as we measure this, we're going to use it from the nose to the tip of the earlobe right there. That's how we're going to measure these to try to get a good size placement. You're not trying to put it too long because then we could block off that airway. Or too short, then we're not effectively in the right spot delivering that breath of air into the lungs. Then we'll deliver a lot of that air into the stomach. Definitely don't want that to happen. Again, this is a very short-term, temporary type of airway access. Then we have what's called a laryngeal mask airway. So I have a couple different of these. This is more of a supraglottic airway. So as we insert it orally, we're going down and around, and we are putting it right there at the base of the esophagus. And we inflate that cuff around it. It creates this nice seal for us. So our main goal is to direct that air down into the trachea, down into the lungs. With that seal, less chance of it going down into the stomach. Again, these paramedics, people in the field, are really trained to put these in pretty quickly, emergency type situation. They will use these sometimes in anesthesia as well. Real short-term fix, they may not fully intubate you. They'll put in an LMA and you may be able to ventilate this way while you're under sedation. I don't have a tracheostomy tube itself, but at this point, I feel like we've all done trach here at some point, probably all in the exact same patient. Y'all are all fans of tracheostomy tubes, I know. Well, let's talk about it just a touch. So they have a single lumen versus a dual lumen. Y'all are all real familiar with the dual lumens, where it has a nice base plate, it has something more permanent that stays inside that trachea, and then we change out that inner cannula. That's that dual lumen. The single lumen has just all one piece where you don't change nothing out. You kind of clean around the hub, you suction out pretty well, and you can kind of clean out that airway. I haven't seen those in quite a while, if at all, honestly. You see more of the double lumens most often. With tracheostomies, they have a really good benefit. It clears basically everything up, besides like an endotracheal tube. If you have an endotracheal tube, it's gonna sit down in that oral airway and go down in to the bronchioles. With that, we're passing over the voice box, we're passing over the epiglottis, we're passing over a lot of different things. So patients with these, this is a long-term, more permanent solution to an artificial airway if they have to have an artificial airway for a very long period of time. All the other ones we've been talking about is a really short, temporary type fix. With these, I can still deliver high pressures of ventilation, but then it's very easily weanable at the same time, and where I'm trying to take them off of mechanical ventilation and allowing them to breathe or ventilate on their own. And it's a whole lot more comfortable. Doesn't look comfortable to me, but if you think about it, instead of having all this junk in your mouth, you have just a simple hole where your trach is going to be. So it is going to be a little bit more comfortable. They can mouth a little bit, talk a little bit, and just not have their mouth directly open with something sticking in it. Okay. So there's a good example of placement. Endotracheal tubes. This is something that y'all starting to be introduced to. Y'all have seen a few times now since we've been in the ICU during your clinicals. So your endotracheal tube is just this real long, flexible, pliable tubing. We can go in orally, but you can also go in nasally as well. They have some of those. You're going real small diameter with your nasal. You can also, and I've seen it where they put the endotracheal tube through the tracheostomy opening as well, and it sticks way far out. I don't really like those because they're very hard to stabilize and keep in the right exact spot. Our goal with these, 2 centimeters above the carina. What does that mean for me? Anybody know where that's at? Where the lungs branch off, good. So those 2 bronchioles split right there. That's about where we're trying to head for, okay? If I go too far, I may only oxygenate one lung or the other. So I'm trying to sit it right above where they split, so I'm equally distributing that air, equally oxygenating both lungs, delivering that breath of air, all right? With your endotracheal tubes, a couple things that are gonna be very important for us. You must get a chest x-ray for confirmation. That's important to know. We've got to have a chest x-ray to make sure it's in the right spot. Initially, when these are gonna be placed, we're gonna listen for lung sounds. We're gonna listen to the left side, and then we're gonna listen to the right side. Make sure we have equal breath sounds on both sides, the bilateral breath sounds. And then we also sometimes will listen to the stomach to make sure we don't hear any air being delivered into the stomach. Then we went the wrong direction. during intubation. Your other good placement tool is going to be what's called a waveform capnography. Waveform capnography. This is where we are measuring that CO2 level. So as we deliver that breath of air, and then as they exhale, they're exhaling that CO2, and it detects the amount of CO2 that's within that breath, and it's going to give us a good indicator if we're in the esophagus or in the trachea. If we're in the esophagus, are we going to get high CO2 readings? No, right? Shouldn't. Right? If we're in the lungs, in the bronchioles, 2 centimeters above that carina, we should get pretty good amount of CO2 coming and going. So I got a couple of examples. These comes in all flavors and sizes as well. Good things to know with your endotracheal tube. What size is it? How are you going to determine your size? It says it on the package for one, so when you initially intubate somebody, you'll have that. But if they have been intubated for a long period of time, the sizing is right here on the very end of your endotracheal tube. All right, so this part right here is going inside the patient, and this is what's going to be connected to the ventilator on this side. So you'll see it. This one is a 5.0 right here, this tiny little one. I mean, you can go down to like a 2.0, 1.0 for the little babies, the NICU babies. It kind of looks like a coffee stirrer, real tiny. So you note the size, and then you're also going to note the measurement along the endotracheal tube. So you'll see these little tick marks along the endotracheal tube. So as I'm initially going in and they intubate, I need to note, all right, it's 22 centimeters at the teeth. We're gonna measure at the teeth. We're not gonna measure at the lips. Lips swell. If we have trauma or any kind of anaphylactic reaction or any kind of edema, it's gonna settle sometimes in the lips, and those lips can grow, and then our measurements could be off. All right. So you either measure at the teeth or the gums when we're measuring endotracheal tubes. Initially, when we're intubating, it comes in 2 separate pieces here, what's called a stylet. So it's really just kind of a stiff tubing. That's kind of pliable, but it's pretty stiff, kind of like a pipe cleaner almost. And it just kind of gives the endotracheal tube a little bit of rigidity as we're intubating to kind of glide it in and get past down that epiglottis, down into that trachea. That's what we're trying to get to, on down past that. And as they intubate, the physician or the anesthesiologist, whoever, feels like they're in the right spot, then they'll tell you to pull the stylet out, and it just leaves this piece in right here, and then you can chunk the stylet. So it kind of comes in 2 pieces. So to recap, remember endotracheal tube, just this long flexible tubing. Our goal placement is 2 centimeters above the carina, or where it splits. For confirmation, initially as we're intubating, during the procedure, we're gonna listen to lung sounds on the left side and the right side, compare the two, make sure we have equal breath sounds. We're also gonna place that waveform capnography tubing on the end of our endotracheal tube to make sure we have that CO2 coming in and out. Sometimes they have what's called a color change. So it's a little piece on there on the end of your endotracheal tube that will change colors when it detects CO2. Otherwise, it's gonna be on the monitor. So everybody has been in the ICU so far, and has everybody seen the little yellow waveform for the CO2 detection? It's gonna start to show up on that monitor, and that's how we know we're in the right spot. Best thing for it though, even though we have checked the CO2 and the lung sounds, a chest x-ray. That's the number one thing, chest x-ray for that. Megan.
So I know paramedics can wear their scope is to place some of these.
Yes.
Is it in nurses'
So,
room?
no, just say no for now.
Is it like OPAs and?
No. You might be specialized and you could train to do those kind of things, and then, certain facilities may allow you to do that. At East Alabama, we're not allowed to put any really advanced airways in. That's gonna be a respiratory therapy call or a physician. If you're a paramedic in the ER, sometimes they'll let you do it, but for the most part, nurses are not gonna do these. Unless you go to CRNA school, and you can have fun, but, regular, brand new grad, no, we're not touching these. Alright, so again, our placement. This one doesn't give an adequate representation, but right there, 2 centimeters above that carina. As we get to about where we are thinking, or the physician thinks, yeah, that looks like a pretty good spot, he's gonna tell us to inflate that balloon. So there should be some type of pilot balloon, one of the ones that's going around, it has an extra balloon passing. Yep, there you go. So it's called a pilot balloon that sticks off the end of this. We're gonna hook up a 10 cc syringe to it, and we're going to give it 10 cc's or infuse 10 cc's, flush 10 cc's, whatever you wanna say, and it's going to blow up the balloon at the end. So right here at the very end of it, right there, that's our goal. We're not gonna add any more. 10 cc's is gonna be our max for now. We're trying to create an adequate seal, so as we deliver that breath of air, it goes further down and not back up. If we don't have that adequate seal and we deliver a breath of air, it's gonna come back up more because it has a chance to escape up and out, all right? With these, never cut these, so never put scissors near these, because then you can pop your balloon. Other things, we're gonna tell you for now to not add more air to it. Don't add any more air to it, because this thing could pop, and it also is creating more and more pressure along that trachea, and then we could develop an ulcer because it's something foreign in there pressing up against that trachea right there. And so it's gonna potentially cause a pressure sore. You can talk to respiratory therapy. They can check the levels in here and make sure we have an adequate pressure amount of air, and then they can add another cc or 2 of air. As you go through your ICU clinicals as well, you may see some of the more trained nurses too add a little bit of air into it as well, if they don't have an adequate seal. Okay. I don't have a syringe, I would show you. But does anybody else want to see this? Okay. The process of intubation. The process of placing this endotracheal tube. So here's our steps. This is the things we gotta think about. Is it elective or is it emergent? Hopefully it's elective. The emergent ones are a little scary, a little sketchy, if we're being honest. Real fast paced, and they're kind of just throwing these things in there hoping for the best. So hopefully we know ahead of time that we need to place one of these endotracheal tubes, and we can go ahead and do it and have a nice, calm, stable environment where we have all our supplies ready to go, and then the anesthesiologist can come in there and just do a nice, calm procedure. We're gonna gather our supplies. So what kind of supplies do we need? Anybody? Yeah, we gotta have the endotracheal tube, right? That's kind of important if we're gonna intubate somebody. We need that endotracheal tube.
Laryngoscope?
Yeah, we potentially have a laryngoscope.
Suctioning?
Suctioning, go. We need suctioning at bedside. As we're opening up this airway and as the physician is opening up that airway and looking down, you gotta think about all those nasty secretions that might be up there. Maybe there was some trauma. Maybe we have to suction out some of that blood as well. So we definitely need some bedside suctioning, if at all possible. What else? Securement, right? So when I put this thing in, am I just gonna let go of it? Hope for the best? And so we need some type of securement, whether that be tape or an actual tube holder. Preferably a tube holder, but if you don't have one, you can use tape very temporarily. The tape is not quite as good, but it does work. All right. What else?
Stethoscope.
Stethoscope. Why would you need a stethoscope?
Auscultation.
Got to auscultate, right? So it's somebody in that room should have a stethoscope on them. And you would be surprised, you'll have 15 nurses and 100 RTs in there, and not a one of them has their stethoscope on. So it does happen, but it is what it is. Okay? So we should have a stethoscope on us. What about a 10cc syringe? Probably need one of those, right? Because I got to inflate that balloon. So we have it right there in that picture. So I want to have that readily available because as soon as he places that endotracheal tube, I got to blow up that cuff to make sure it stays in place. All right? Any other thoughts? And boo bag? Yeah, that's good. We're giving them all these drugs, and we'll talk about them in just a second. Probably need to help them with their airway until we establish an artificial airway. How's that physician gonna put that thing in and open up that airway? Gyroscope, more than likely, yes. We also have a handle and blades as well that we're going to use, or the physician's going to use to open up and tilt that head back so he can get a good visual of that airway and where he wants to place that endotracheal tube. And so we will grab some of these things. We'll grab the handles. There's a couple different kinds. Most of the hospitals are going to more of these disposable kinds, so you can just chunk them after use. And then you'll still see some of these older old-fashioned ones. These are not chunkable. They wipe these down, reuse these, but there's a little light at the end of it. So it gives a little bit of light to that airway. With the handle, we need the blade as well. Because as we're sticking it into their mouth, up and away, this is a big one. That's a real big one. That's what I had. That's what Hannah gave me. So this one's expired apparently. Anyway, I gotta have that blade so as I'm placing it into their mouth, and they can open it up. And then it has again that little light at the end of it to open it up. There's two different kinds. There's Mac blades versus Miller blades. What's the difference? One is straight and one is curved. All right, Sam, which one's straight?
No, I don't know. I was just saying.
You're right, it is one straight and it is one that's curved. Miller straight, you sure?
Yes.
Yes, good. All right, Miller is straight. So see the difference? I know this one's really huge too, but this one's pretty straight, right? Okay.
It's like an animal.
I know this one's big. I've never seen one this big, but that's, like I said, this is what I had available. And this one's more curved, right? So you can see the difference. The way I think about it, Mac ends in a C. This looks like a C, so I know it's curved. The Mac is curved, all right? Your Miller's got two L's in it, two straight lines. And you have your Miller blades. Does it really matter that you really know that? Not a whole lot. It's just that information you can have. Does it matter what specific one I grab?
Yes. Depends on your position.
Depends on your physician. Everybody likes something different. I wouldn't like this one, but some of them have like almost their lucky blade and their lucky handle. And they only say, grab me a Mac 3. They'll grab you a Mac 3 and then they intubate. But they can't intubate with anything else. They don't like the Mac 2 or the Mac 1. Wash them hands, Dr. Floyd. And so it's very physician preference as to what size handle I need and what size blade.
Tell them to be quiet.
Let's close this other door.
Are we that excited?
Washing our hands, I don't know. All right, we already talked about the stylettes, which are the little silver pieces, the kind of stiffer pieces that make it a little more stiff, allowing it to, the endotracheal tube to go in and be placed where it needs to. We also have something that's called a bougie as well. Some people just call it like blue stylet, but we call it bougie. So if it's a very difficult intubation, it's very hard to see that airway, and they're not able to float this endotracheal tube into the right spot, down like that. Or maybe they have a very narrow airway because they have some type of anaphylactic reaction or some type of constriction, bronchial constriction. I can actually use this initially to intubate my patient. There's no hole or anything on this, so this is not an airway. This is just to get access to that airway. Once I get access to that airway and I visualize it with something like the kaleidoscope where I can see everything, I can slide this endotracheal tube down, slide it in, take the bougie out, and it's in place. So it makes it a little bit easier for some of those more difficult intubations. All right. Other supplies we need. We're still on supplies. There's a lot of stuff we need for an intubation. What are we using to ensure that it's in the right spot?
An X-ray.
An X-ray. What else?
CO2.
CO2 detector, right? That waveform capnography. Grab one of those. Go ahead and hook it up to the monitor. So as soon as he puts that endotracheal tube on, you can place it on top of the endotracheal tube and get that instant feedback. All right. Probably need the ventilator, right?
I mean,
Unless you want to sit there and ambu bag them all night. That's not my idea of fun. So probably grab a ventilator. Who runs the ventilator?
Respiratory,
Respiratory. Should respiratory therapy know that we're fixing to intubate somebody?
definitely.
Probably so. Otherwise, you're just gonna be hitting buttons on the ventilator and hoping for the best, right? Respiratory therapy went to school for 2+ years or more, just like y'all did, just to take care of the ventilator and airway. That's their only job, is to take care of the airway. Let's get them involved, all right? We're also gonna have some type of fluids on board. Usually we're gonna have normal saline. A lot of times we don't put it on a pump, we just let it free drip. All right, so we'll just spike a bag, usually a 500 cc bag, maybe 1,000 cc bag of normal saline, and then we'll prime our tubing and then we'll hook it up directly to our patient. Make sure you have reliable IV access. All right? Make sure it's not a 22 gauge in the thumb. We need reliable access if they're going to be intubated. So as those fluids are being infused, it serves kind of a couple of different roles. First role is to maintain our blood pressure. So if our blood pressure drops during this procedure, I can kind of bolus some fluids to give a little bit of extra volume to hopefully increase my BP. It also helps as a flushing mechanism, so I don't actually have to flush my line for the anesthesia drugs, the sedation induction type drugs. All right. So I need some fluids on board. I also need the intubation drugs itself. We're going to talk about those in just a second in a couple slides. But we can go ahead and pool these drugs for the anesthesiologist. So when he comes in, he's supposed to push them technically. A lot of times they just hand it to us though and we push them. But he's supposed to push the drugs technically. But he'll tell you how much he wants drawn up. And then you hand it to him and he will push them. A lot of times they'll use succinate, and then they'll also use etomidate as well. One is a muscle relaxant, kind of has a paralysis type effect, the Sux does. And then the etomidate has an anesthesia property to it, to kind of make you sleepy, has an amnesia effect with it as well. With these two drugs, I need to know my lab values. So that's why I have these lab values up here. Most specifically, my potassium level. With your Sux, it's gonna increase my potassium level, the way it works in our system. So a lot of times that physician's gonna walk in, hey, what's my potassium level? And then he can figure out how much Sux he actually wants to give, or does he wanna give it at all? 9 times out of 10, he's gonna push it and hope for the best, but he's gonna ask for that lab value as well. And then etomidate, it's rare, but it can actually decrease your potassium too. But you wanna have your lab values, all of them, pulled up, so even just pull up your chart in the room. So if that physician wants to ask any questions at all, you have that chart readily available, you can click through it and tell him everything he needs to know before he goes in and does this procedure. Anything else we need? That's a lot of stuff, right? Really, the only other thing we're gonna need is some Kentucky jelly or some KY jelly, just to lube the end of the tube. Unless they're extra moist on the inside, then they won't use any lube. A lot of times they'll put a little bit of lube on it too before they put it down, okay? So if it's elective or emergent, we gathered all our supplies. Remember, we initiated those fluids, that normal saline, just at a steady, continuous drip. We're not really putting it on a pump. I told my physician the lab values, so he knows those. Now, what is my role as a nurse during intubation?
Monitoring vital signs.
Monitoring vital signs. What else? Anything?
Lung sounds.
Lung sounds, right? You're kind of the workhorse. Yes, you're task forcing. If they need anything, need you to grab anything, you're monitoring their vital signs. So you're looking up that bedside monitor, making sure our heart rate doesn't slow down. Our BP doesn't plummet all of a sudden because we're giving them these big sedatives and these muscle relaxants. Our blood pressure is going to take a hit at some point. Sometimes you may be assisting more at the head of the bed as well while the respiratory therapist is getting the ventilator set up. So if it's in an emergency situation and we don't have time to plan for these things, that respiratory therapist is going to set up the ventilator while you're bagging the patient, waiting for that anesthesia to kick in and making sure that patient's fully asleep and fully relaxed before he attempts to place an endotracheal tube. So we're kind of pre-oxygenate them, we're bagging them, getting them ready to be intubated. And then that physician will say, all right, let's try it. And he'll try to place that endotracheal tube as well. So you may be just kind of assisting that physician. And like I said, you might also potentially be giving those sedation type drugs as well. Remember, waveform capnography, very important. If I'm not in the right spot, then I'm more than likely in the esophagus or down into the stomach. So as I deliver those breaths, even with the ambu bag or the ventilator, I should not get any CO2. What else would I notice about my patient if I'm delivering air into the esophagus? I hear bloating in the back over there. Bloating, yeah, so their stomach's gonna rise, right? It's gonna get real tight, real taut, and you'll see that because there's so much air that we're introducing into that gastric space. With that, we gotta think about nausea, vomiting, potential aspiration risk because we're introducing so much air into that as well. Listen to those lung sounds. What if I don't hear any lung sounds on the left side, but only on the right side?
One side.
Went too far, right? We only went to, we went one direction. That's called a right main stem. That's gonna be something you hear a lot. Usually that's what's gonna happen if we go too far. Just with the natural anatomy, the first place this endotracheal tube is gonna go after the split is to the right. It naturally curves that way. You can get a left main stem every now and then, but it's pretty rare. Like I said, just the way that we are created, the natural anatomy of ours, that endotracheal goes down. If it goes too far, it's gonna go to the right. We call that a right main stem. So as you're listening to those lung sounds, as that physician or respiratory therapist is delivering those breaths with an ambu bag, or they've already connected them to the ventilator, we're only gonna hear lung sounds on the right side. Hopefully, physician has not left the room. He shouldn't, because we haven't confirmed placement, but he'll be able to pull it back out a little bit until we hear lung sounds on the left side and the right side. Does that make sense? And then that's why we're gonna get that chest x-ray to make sure we're in the right spot. At that point, when you're pretty much confirmed with a waveform capnography and listening to lung sounds, I'm gonna go ahead and secure it with one of the tube holder, and you've seen a couple of those, or some tape, something like that. Questions about the process of intubating? It sounds like a lot, but it's a pretty quick process once it gets done.
Is that what happened to that patient in the code the other night? They got into her stomach. They didn't hit the airway.
I don't think so, yeah. I think they got into her airway a good bit. Every time they were bagging her, or trying to bag her, her belly was getting tighter and tighter. And then as they pulled that endotracheal tube out, she was actually kind of burping up that air, or expelling that air, and you could hear it. And then she wasn't getting oxygen at all. We also had a waveform capnography piece on the end of the endotracheal tube to see if we detected any CO2. We didn't detect any CO2. So, but you gotta think about it. This is an emergency situation. I was actively doing CPR. Zach was doing CPR, a couple others. Meredith was the recorder in the back over there. And Josh was doing compressions as well. The body is moving the whole time because you have a big guy like me or somebody else jumping on that chest, basically, essentially, pushing that chest down. So that airway is moving, right? It's going all over the place. It's gonna be hard to hit that. So sometimes they may get you to pause so they can intubate appropriately. Stephanie did compressions too. Sorry, didn't mean to leave you out. There you go.
The nurse got that IV though.
She did get the IV. I was very impressed with that.
impressed about that nurse,
Yeah.
Great.
So when we're intubating some people, we can also have complications as well, and this is gonna tie into that mechanical ventilation piece as well, about the different types of complications. Infection. This is not a sterile procedure, but we hope to have it as a clean procedure as possible. With that, there's potential for that aspiration risk as well. And so we have some of those foreign bodies getting into that lung space. We potentially develop some type of aspiration type pneumonia. All right. Trauma to the airway, or trauma to even to the teeth. A lot of times as they're shoving these blades in, they're not the most careful sort. These are real stiff blades right here, okay? As they're going in, they're gonna hit those teeth. Maybe they crack the teeth, or they have dentures, so the dentures get caught. Hopefully they take the dentures out before they start the process, but you never know. And then we're shoving a foreign airway or foreign object into the airway. That's gonna cause trauma to that area as well. So that's gonna cause some trauma as well. That one doesn't light up, but it's still there. And then a pneumothorax. What is that?
Air in the chest.
A tear in the chest.
Air.
Oh, air in the chest. I thought I heard tear in the chest. I guess
It
tear in
could
the
be.
pleural space, maybe. Pneumothorax, air in the chest. We could potentially collapse along with this process as well. Just think about. So here's a portable chest x-ray to confirm placement. Again, I'm not trying to get you to interpret a chest x-ray, but just for a visual effect, we're trying to get it about the level of the collarbone. That's about where we're trying to go for. This one may be a touch deep, but not too bad. So does everybody see this kind of thick, thin, white line right here? And then there's a little bit of a tip right here, you can see it. And then you can kind of see the shadowing on the other side as well. This is that endotracheal tube right here. That's what we're seeing. So let's look at an intubation just to see